If you're in midlife and wondering where the hell your desire went or how to get it back and make it hotter than ever, you just found your show. I am Dr. Stacy, clinical sexologist and certified sex coach, and this is the Purple Passion Project, the intimacy and sex podcast for midlife and beyond. Just real spicy conversations about desire, intimacy, and pleasure that will change the way you think about your sex life forever. Let's do it. Hey everyone, I'm Dr. Stacy, and this episode is brought to you by my pleasure playbook called Desire with a Diagnosis. It's the guide that I wrote for anyone whose body stopped following the old rules, from surgery to chronic pain to a diagnosis that nobody warned you would follow you straight into the bedroom. So if you've ever felt like your body was working against you the second things got intimate, this guide was written for you. So grab it at drstacyfriedman.com. The link will be in the show notes. And speaking of bodies that don't follow the rules, that is exactly what we're getting into today. So welcome to the Purple Passion Project, where we talk about sex, intimacy, and all the deliciously naughty things that you've been thinking about, but nobody gave you permission to say out loud. Midlife is not where your sex life slows down. It's when it gets hotter than ever. So buckle up. Here we go. And today it's just me. So we're going to be talking about what happens to sex and desire when your body changes the rules on you. So not just the big stuff like prostate surgery, hysterectomy, or heart procedures, but also the everyday stuff, such as everything I have. Bad knees, bad hips, bad backs, torn shoulders, stiff shoulders, whatever it is, things that make certain positions feel like a workout that you did not sign up for. And then there's hormones, menopause, low testosterone, thyroid shifts, rewriting your desire without so much as telling you this is what's going to happen. So here is where we are starting. Your body changed. Your sex life did not end. It just needs new rules, maybe some new positions, but honestly, a lot more play than you would expect. So let's start here, because if we don't get this part right, nothing else today is going to make sense. So your body changed. Maybe it was surgery. Maybe it's a new diagnosis. Maybe it's just years of wear and tear on a body that used to show up and perform without complaining. And then somewhere in there, sex started to be more complicated. So most people don't lose their desire after their body changes. They lose confidence in their body. And those are two totally different problems. And we treat them like they're the same one. So desire doesn't disappear. It goes into hiding and it kind of waits until the body feels safe again. So if you stop initiating, stop putting yourself in situations where intimacy might happen, stopped feeling like a sexual person at all, I want you to hear this. Your desire didn't fail you. Your body is just protecting itself the same way it would after any kind of injury or scare. Think about, for example, a dog that maybe has gotten bitten and is skittish around other dogs for a while, even friendly dogs. That's not the dog malfunctioning. It's just the nervous system doing its job and protecting the dog from getting hurt again. So the same thing will happen. Not that I'm comparing us to dogs, but it's the same idea. The same thing happens when with sex, when you have a body that is unpredictable, pain flares up, incision is healing, a joint that's not cooperating, the brain starts treating intimacy like it's going to be a potential risk and not a reward. So it pulls back to protect you. So let's get specific about how desire actually shifts when the health changes, because it's rarely one dramatic loss of interest. It's 5 small little changes that stack up on top of each other. So desire stops being spontaneous and becomes responsive instead, meaning you might not feel turned on out of nowhere anymore like you might have before, but you can still get turned on once things get started, if you give yourself that chance. So arousal may take a little bit longer to build, or it needs different stimulation than it used to. Fear of some symptoms shows up before the curiosity does. So you're bracing yourself for pain or fatigue before you're even thinking about the pleasure. So your mind stays alert instead of just dropping into that sensation. Confidence will take a hit before pleasure even has a chance to. None of that means that something is wrong with what your body is doing. It just means you need to adapt, and adaptation is going to look different now than it did 20 years ago. So here's where people get stuck. They try to have sex exactly the way they used to, and it doesn't work the same. And they decide, I can't do it this way, something is wrong with me. That comparison is the actual problem, not the diagnosis, not the surgery, not the age. You cannot run today's body, especially in midlife or older, on yesterday's rules. You just can't. And I am proof of that. So this is why silence does more damage here than the diagnosis itself. Because when you describe what's actually happening in your body without apologizing for it, intimacy has a much better chance of coming back. Not because the symptoms actually disappear, but because you're not guessing as to why are you not doing this? What's going on? The guessing just stops. So let's talk about what actually rebuilds safety in the bedroom, because safety has to come before desire can actually show back up. So first of all, it's predictability. So choosing the time of day when your energy is the highest instead of maybe waiting for the mood to strike spontaneously, because you may not have that. So you might want to build a small ritual around intimacy instead of just hoping that it's going to come back on its own. And then take performance pressure completely off the table. Sex does not have to lead anywhere to count. And if you are not able to or not in the mood to, there's other ways that you can either help your partner take care of things, or your partner can take care of things on their own. Second is comfort. And this is where lube, pillows, positioning supports, things like this, which will also, it's called the Liberator. This will also be in my show notes. These are great for different positions, to put your arm on, to put your butt on, to put your back on, to lift your hips up. These positioning supports are amazing. And also temperature control. Make sure that that's comfortable, because you don't want to be shivering or you don't want to be too hot and have things bother you even more. So you want to make sure that you're also managing your pain before intimacy starts instead of pushing through it, because then you're not going to be in your body. You're going to be watching and in your mind above. And give yourself permission for shorter sessions that prioritize the quality over the endurance. Do a little quickie so you can connect. That can definitely be helpful. The third one is communication. So practice describing what's happening in your body without apologizing for it. You don't have to apologize, say, I'm sorry, I'm not in the mood, my leg hurts or my back hurts. You just want to explain and describe it so your partner can understand. So use neutral language instead of shame-based language. You don't need to shame yourself for not wanting or desiring when things are not feeling right. And make sure to separate your desire from your ability. You can want sex, but still need the accommodations. Those two things are not in conflict with each other. And so there's one more piece before we move on, and it's the piece that people skip fastest, and that's grief. You're wondering, well, grief? What does grief have to do? There's often genuine grief when intimacy changes, grief when you're not able to do what you used to do, grief for the spontaneity, for ease, the version of sex that didn't require planning or courage. Ignoring that grief doesn't make it disappear. It just turns into you withdrawing. And you need to just let it exist. Know it's there. Grieving the old version of your sex life makes room for a better one. You're not mourning sex. You're just mourning the loss of it being effortlessness. Being able to just be like, okay, I'm ready. Let's jump. Let's go in all these different positions. That is a loss, and it's okay to grieve it, but just let it exist and just look forward to what's to come in different ways that you can make it fun. Effortlessness was never the same thing as pleasure anyway. So one last thing before we get in today's get into today's specifics, this episode is going to lean a little lighter and a little more playful than usual on purpose. And the subject matter is heavy enough on its own. So surgery, chronic pain, hormones, we're going to try to laugh a little bit, get a little bit creative, and remind each other that getting older in this body is a team sport. So let's get into it. So what this means for your partner. If you are listening to this with a partner, or your partner isn't a diagnosis away from any of this, but you are, here's what actually helps on their end. So partners often default to one of two extremes. They either avoid initiating altogether because they're terrified of causing pain. They don't want to hurt you, or maybe they'll make something worse. So what they do is they overcompensate by never asking or never initiating, and they just assume everything's fine. And neither of those works because you're sitting there wondering why they're not wanting to connect with you. So what works is just asking a simple, low pressure question before intimacy starts. And it could be something simple such as, what feels good tonight and what should we skip? And that one sentence does more to rebuild trust than any amount of just walking on eggshells because you don't know what to say. Just ask, what feels good? What feels good right now? And what should we skip for next time? Partners also need permission of their own too. And it's okay to still want sex even while your partner is navigating a health change. So wanting intimacy doesn't make you selfish. It makes you human. But the goal is not for one person to shrink their needs so the other feels safe. It's for both of you to actually say what's true, what you can do, instead of assuming. So fear that goes unspoken, that concern that goes unspoken, is what actually damages intimacy here, not the diagnosis itself. So telling your partner plainly that you're scared of causing pain instead of letting them assume that you have no interest, that can change the dynamic almost immediately. So when you tell someone just relax, I've been told that many times by doctors, just relax. Why that doesn't work. People want to tell you just to fucking relax. Okay. It's like, if you could just, oh, okay, sure. I'll just relax. Let's just flip a switch. Physiologically, relaxation is what allows arousal to happen, but you can't force your way into it, especially when your nervous system learned that this body is unpredictable. I don't know what's going to hurt, what's going to happen in a daily basis. What actually works is removing as many unknowns as possible ahead of time, so your nervous system has less to guard against. So that's really all the tools we just covered are doing: predictability, comfort, and communication. These all reduce the unknowns your body is bracing for. So which is what finally allows your relaxation to happen on its own instead of being forced. What might be a good idea is we have a yes, no, maybe list for people that don't have any issues. You could also get that free on my website, drstacyfriedman.com. Under free sex tips, there's downloads. There's free downloads there. One of them is a yes, no, maybe list. But you could build your own yes, no, maybe list in relationship to what you're dealing with right now. So here, this is a concrete tool that you can start using tonight. So sit down separately or together if that feels more comfortable, and make 3 columns: a yes, a no, and a maybe. You want to list different types of touch, activities, and positions in each column based on where your body is right now, not where it used to be, because that's what my free one on the website is. That's just generalized. But do this now with the 3 different sections. This isn't a one-time exercise because you may need to revisit it monthly. If it's surgery, it may change as you heal from your surgical process, or if you have a chronic disorder or dysfunction that's causing constant pain or things like that, you may need to revisit it monthly because your body will change. Bodies with medical conditions change. And what's a no this month might be a maybe the next month, or the reverse. So having this list means that you're never trying to have an entire complicated conversation in the middle of an intimate moment. So you've already done the thinking in advance, and you could take a look at it prior to being intimate. So there's a few questions I get asked constantly. One of them is it too selfish to want sex when my partner is dealing with something bigger, like a serious health issue? The answer is no. Desire doesn't take a back seat just because life gets more difficult. It definitely can change shape. It definitely can hide, but wanting connection is not a character flaw, even when you're dealing with hard situations. And so having this desire, that's where that communication comes in to find out what your partner is open to during that time. Another question I get is, what if I try to talk about this and my partner shuts down, which happens very, very often? So you want to start smaller than you think you need to. Don't just say, I want to have sex. You don't have to have this whole conversation in one sitting either. So one honest sentence tonight is more progress than a perfect script that you may never actually say. And so what you want to do is say, well, I really feel like I'm missing your connection. I'm missing our intimacy. Are we able to cuddle more? Don't just go, are we able to have sex? After that, maybe a week later, just say, do you think that maybe we can take a shower together and connect and wash each other? Have smaller little steps if your partner does shut down. Next question I get is, what if nothing works the way it used to, no matter what we try? And so I like to tell everybody, the goal is not getting back to the old of what it used to. It's building a new. And that's genuinely the whole message of this episode. You can't expect yourself to be the way it used to be. And that's kind of where that grief comes in I was talking about. We want it to be that way, but that doesn't mean that's the way it is. And so we have to look forward to, how can we change this to have fun and make it something new? And so before we move into the specifics, here's something to actually do, not just think about. So pick one moment coming up where you'd normally avoid initiating because your body feels unpredictable and not sure if you would want to do anything. So instead, say clearly what you need. Let's say, for example, a pillow, a slower pace, permission to stop if something hurts. Just one sentence, because sometimes you don't know if it's going to hurt, so you avoid it. But if you say, I'm not sure if I'm going to feel good, but I'd like to try, and I want to make sure that if I don't feel comfortable, it's okay to stop without, getting into arguments, because that could happen. That's it. Just one sentence. Ask about a pillow, a slower pace, or something to stop if you don't feel good. Watch what happens when you stop pre-deciding the answer for your partner and actually let them respond to see the information that they bring to you instead of just guessing what they're going to do. So before we do, give yourself one piece of permission. You are allowed to grieve the version of sex that used to be effortless. You're allowed to grieve that spontaneity. Doesn't mean you can't have it, but it may be different. Grieve not having to think about, deal with it, worry what's going to hurt, and then get curious about, what is your body asking for now? I just bought a piece of furniture, a piece of sex furniture, because it's much more easy to do something on a specific piece of furniture that allows me to move and be in different positions that are not painful. Figure it out. Ask for what your body is needing right now. There's a version of your sex life on the other side of this that's just as hot, maybe even hotter than the one that you are mourning. It just needs some new rules. And so real quick, I want to tell you about something that I absolutely love, and that is my Vibe Tribe community. So if you've been listening and thinking, oh my God, that is so me, there are people inside the Vibe Tribe community saying the exact same thing, because it's all about midlife. It's equal parts fun, naughty, educational, uncensored, and it's the kind of connection that will make you laugh, make you think, and make you wonder why you weren't in there sooner. The connections are great. So go to drstacyfriedman.com, click Vibe Tribe, and come find your people. You get a week free try the elevated men's or women's group so you can have courses and the lives, and it's a very minimal charge. So in this section, I want to talk about surgery, mobility, and just the everyday stuff. So let's get into specifics, starting with surgery, such as prostate, hysterectomy, heart procedures. I want to walk through what actually changes with each, because half the anxiety around sex and surgery comes from just not knowing what to expect. And a lot of times doctors don't even tell you. So it's important to learn and educate yourself. So for example, prostate surgery, depending on whether the procedure was nerve sparing, you may see erectile changes that are temporary or changes that need ongoing support. Medications such as a PDE5 inhibitor, a vacuum erection device such as a pump, which I do have also, which I'll put in the notes, or maybe even injection that you get at the doctor's office. Recovery is not instant. It could take months. It can take anywhere from several months to 2 years for full nerve function to return. And make sure that you're not judging after 6 months and saying things are not where they are supposed to be. You need to give yourself time. And starting also, what urologists may do is a penile rehab, making sure that you are doing any type of rehab they tell you, such as using the tools consistently, such as the pumps, even before you're trying to have partnered sex. That genuinely improves your long-term outcome. Ejaculation will change as well. Many men experience what they call dry orgasm after prostate removal. And I want to be really clear, this still counts. It's just called retrograde ejaculation. The sensation is still there. The pleasure is still there. It just doesn't look like it used to. So the biggest mistake that I see men making here is treating that erection function as the entire measure of their sex life. It isn't. There's an enormous amount of pleasure available to you that has nothing to do with the erection or the ejaculation. The next one I want to talk about is hysterectomy. So the specifics matter here. If your ovaries were removed along with your uterus and you weren't in menopause, you're not just recovering from surgery, you have dropped into surgical menopause overnight with none of the gradual transitions that your body would normally get for years potentially. That is a hormone cliff you are diving off of, not a little slope that goes down, and it deserves its own conversation with your doctor about hormone support. Even without ovary removal, you may notice some scar tissue or changes in vaginal sensation, or a fear that penetration might feel different than before, or just even tearing the vaginal cuff if you've had the entire cervix removed as well. Most surgeons will clear patients for intercourse around 6 to 8 weeks post-op, but cleared for intercourse and ready for intercourse are two totally different things. So give yourself genuine recovery time before you start measuring your performance against where you used to be. I know after my hysterectomy, they told me at 6 weeks I was ready to go. There was no way. I had intermittent bleeding. I had nervousness, pain, discomfort. It takes time, because if you think about it, when you have your cervix removed, you have a vaginal cuff this big. You're afraid that if you have normal sex, what do you say, normal sex, any type of penetration, that it could mess up your stitches. It could do, you need time to really get through this. It took me almost about 12 weeks. So allow yourself that time. Now we have heart procedures, stents, bypass surgery, a new pacemaker. This one's sneaky because it's rarely about the body physically being unable. It's about that fear of your heart rate spiking, fear of doing damage. And it's not just the patient's fear. Partners get scared too. And sometimes a partner's overprotectiveness becomes its own barrier to intimacy, because they don't want to do anything that's going to affect your heart, even though the doctor says you're good to go. It's scary. And most cardiologists use a simple benchmark. If you can climb 2 flights of stairs without chest pain or serious shortness of breath, your heart can handle sex. So if you haven't had that specific conversation with your doctor, that is homework for both of you before this episode is even over. You can pause it and make a phone call. So always check with your doctor. This fear rarely gets addressed directly with a cardiologist, and it doesn't need to drag on for months. Just one quick, direct conversation with your doctor usually resolves it. Then we have joint replacement surgery. Hip and knee replacements deserve their own mention because so many people going through them are in midlife, they're active, and they're completely unprepared for how it affects intimacy. So you have most orthopedic surgeons, they clear patients for sexual activity around that 4 to 6 weeks post-op, similar to other moderate physical activity, but nobody actually tells you what positions put stress on a healing joint and which do not. So a general rule is avoid deep hip flexion for at least the first 3 months after hip replacement specifically. And that means positions requiring you to bring your knee towards your chest. Those should be off the table temporarily. Or side lying and less flexed positions, those are your friend here. So, and just like every surgery we've talked about today, the timeline for medically cleared and the timeline for actually mentally cleared are two different calendars. So let your body set the second one and check with your doctor if you have any questions. So pelvic floor physical therapy. I want to mention this one specifically because almost nobody gets referred to it, and it helps with nearly everything that we have covered so far. Prostate surgery, hysterectomy, even general chronic pain, because you don't know where that pain is coming from. It could be from the pelvic floor. A pelvic floor therapist works with muscles that directly affect arousal, sensation, and comfort during penetration for men and for women. So if your surgeon or gynecologist never brought it up, ask them directly. It's one of the most underused resources in this entire conversation. Then we have arthritis and chronic pain. So osteoarthritis and rheumatoid arthritis both show up constantly in this midlife and older population. And the sneaky part is that pain and stiffness fluctuates day to day, sometimes hour to hour, and sometimes depending on the weather. That unpredictability is exactly what erodes the spontaneity because you generally don't know at 8 o'clock how your joints will feel by 9. So the fix is not forcing spontaneity to work anyway. It's building in a quick check-in right before intimacy starts. A simple scale works. Let's say on a scale of 1 to 10, where's your pain right now, your discomfort? And does that change what we tried tonight? That's not unsexy. That's basic communication. It's the same as asking what someone wants for dinner, but you're talking about something that can be much more enjoyable. Fibromyalgia and autoimmune conditions. Me. Fibromyalgia, lupus, and other autoimmune conditions, those add another layer that's different from a single surgery or a single joint. Pain that moves, sensitivity that changes day by day, and flares that show up without warning. This is where predictability tools will matter the most because you genuinely cannot always predict a good day in advance. What helps is having a plan for both good days and bad days instead of only planning for the good ones. So on a flare day, intimacy may mean I only want gentle touch today with zero expectation of anything further. And that still counts as connection. You're not required to perform your way through a flare to prove that your relationship is fine. I know with me with fibromyalgia, sometimes my husband will sit there and squeeze my leg to give a little love squeeze, and I'll jump through the roof. There's been times where I've had allodynia, where it's pain to the touch, where even just clothes hurts, or even just a hand on the arm. So there were a couple times where I would have a couple of weeks where I couldn't even be touched, but I could do things for him. I could still be kissed. So you want to still be able to find ways to connect during those times. So then we have another one such as pain medication and timing. So if you are on pain medication as part of recovery from any of the surgeries that we've covered, timing your dose around intimacy is also a completely legitimate strategy. It's not cheating. Some pain medications also affect arousal and sensation. So this is also a conversation worth having with your doctor or your pharmacist rather than trying to guess it. So the goal is being comfortable enough to be present without being so medicated that sensation disappears and dulls all of your sensation. So we have your recovery timeline cheat sheet. So since we've covered a lot of surgeries, here's the quick version to keep straight. Prostate surgery. Erectile function recovery can take months to 2 years. So start your rehab tools early. Hysterectomy, typically cleared around 6 to 8 weeks. Mine was longer for full comfort. Feel your body, see what feels comfortable. Heart procedures, often cleared within weeks once the cardiac rehab benchmarks are met. So ask your cardiologist directly about the stairs test. The hip and knee replacement, usually 4 to 6 weeks, with hip flexion restrictions lasting up to 3 months. So these are general ranges, not promises. I'm not the doctor. Your surgeon's specific clearance always overrides anything that you hear on a podcast, including this one. So then you have everyday mobility. So now let's get to the stuff that doesn't get its own awareness ribbon, but touches way more than any of the surgeries we just covered. Bad knees, bad hips, bad backs, stiff shoulders. This is where we get to have some fun, because being midlife and horny in a body that has opinions, that is just, sometimes you just have to laugh with it instead of fighting it. This is what we need to talk about. So if missionary makes your knees scream, you don't need to give up penetration. I know my knees hurt like hell when I'm trying to be on top. You need a pillow, maybe under your knee, or maybe a new angle, or get furniture, position furniture, such as a wedge or a bench, which I'll have in my show notes. If a bad hip, take certain positions off the table. Get creative with different support, maybe being at the edge of the bed. You could also try a wedge pillow for your hips, or even side laying positions that take pressure off your joints and then let you both actually relax instead of, gritting through it. So I want to name a few of these because giving them a name makes them easier to actually ask for. So there's what I call the recliner. So you're propped up on pillows or against a headboard, which is low impact, and that's great for bad knees or backs. Then there's the spoon session, where you're laying side by side, minimal joint stress, ideal for hip issues or when someone just doesn't have the stamina for anything more athletic, a little bit more difficulty breathing. There's also the countertop special, and that is standing support against something sturdy, which takes the pressure off of your knees and hips entirely. And let's be honest, adds a little spice to your kitchen. Or you get something like a swing, where your partner that may have bad knees could be standing while you're sitting in the swing. I'll have that in my show notes as well. And then there's the chair affair, seated positions that are using a sturdy chair for support, fantastic for stiff shoulders or lower back issues where lying flat is not comfortable. And none of these are consolation prizes. They're just as hot and sexy as anything you did in your 20s, arguably hotter because you're not wincing through it and you're actually enjoying it. And it's something fun that you may not have thought of doing prior. So before we move forward, I want to talk about tools, because this is where people either get stuck or move forward. So you have timing tools. So you want to figure out the window in your day when your energy and pain levels are most stable, and then let go of the spontaneity as the gold standard of a sex life. Planned sex can be just as hot. It doesn't mean lesser sex. You have environmental tools, such as easy bathroom access, if that matters in your condition, lighting that may help you feel confident instead of exposed, temperature control, if that helps your body relax. Then you have body support tools, lubricants, positioning pillows, external stimulation when internal stimulation is limited by nerve changes or scar tissue. None of these are last resorts. They're just good equipment to help. And here's the thing worth remembering through all of this. Comfort tools are not surrender. Using a pillow doesn't mean you're giving up on your sex life. Planning sex around your best energy window is not unsexy either. It's just smart. And the couples who plan tend to actually keep having sex instead of gritting their teeth through the one bad attempt and avoiding it for 6 months later. If you are the partner in this situation, the person has mobility limits, here's your job. Stop waiting for them to ask for help and adjusting the position and start asking directly, want me to grab a pillow? Or should we try this a different way? It takes the labor off of the person who's already managing the pain or recovery. So be attentive. Try to look and see if you can help them in the situation. Any drop of performance pressure of your own about needing to know exactly what to do, this will help asking those questions. Nobody comes out of a joint replacement or a bad back already knowing how you're supposed to set things up sexually. You figure it out together with a little trial and error and a good fucking sense of humor. So I want you to try this. Try one adapted position. It doesn't matter which one. Just pick whichever sounds most appealing from what we just covered and give it an actual name together. Something ridiculous, something that makes you both laugh. Positions with names get requested again, and it builds the humor and the connection in there. Positions that just feel like the modified version will get avoided without anyone saying why. So I also want to take a moment to talk to you directly, because if something in today's episode hit a nerve, that feeling is information. So knowing what's going on and actually changing it are two very different things. And that's where coaching comes in. So I work one-to-one with people who are done just surviving their sex life and are ready to have a sex life that is hot as hell, find their desires, their voice, and their confidence in the bedroom and beyond. I offer a free 30-minute private intimacy consult. So that way you can share your needs, your wants, your desires. I can have resources, ideas, tips, tricks. And if you just go to drstacyfriedman.com, at the top of the page, you'll see free consultation. Click it and let's talk. I'm happy to help. So now I want to talk a little bit about hormones and connection, because this is a hidden variable in almost every one of these conversations that no one thinks to blame. So it's one of the questions I ask as soon as I start talking to anybody that has any type of concerns or issues. So for example, menopause. I want to separate perimenopause from menopause itself because they do show up differently. Perimenopause is the years long, 4 years to 10 years lead up where hormones will fluctuate unpredictably. So one month you'll feel like yourself. The next month your libido went away. Menopause itself, 12 months without a period, that tends to be bringing about more consistent type of symptoms. Hot flashes, vaginal dryness, thinning issue, and what's now called genitourinary syndrome of menopause, which can make penetration genuinely painful if it's not addressed. So none of this is imagined and none of this is just getting older. It's very specific, treatable chemistry. Local vaginal estrogen is different than systemic hormone therapy, and it can carry different considerations. So this is a conversation for a doctor who actually specializes in hormones and menopause, not just a quick answer in a GYN's office in a rushed appointment. You will not get what you need. And if hormone therapy is not right for you, there are still non-hormonal options such as specific lubricants, moisturizers, pelvic floor therapy. These can make a significant difference. So perimenopause versus surgical menopause. There's a meaningful difference between the gradual perimenopause transitions that we just described and surgical menopause, which happens literally overnight when the ovaries are removed. Gradual perimenopause gives your body and your relationship time to adjust in small little increments over the years. This is when it's ideal if you do need coaching to get that support, because it's confusing. And here I hear a lot of people saying, well, my wife used to, and now she doesn't, but some days she does, and it's confusing, and I feel rejected. This is where a lot of that comes in, and this is where I can help. Surgical menopause, however, gives you none of that runway. It's like one day you're normal, and the next day you have no hormones left. If that is your situation, advocate hard for hormone support conversations immediately after surgery rather than waiting to see how you feel, because that sudden drop is a completely different experience than that slow fade that most people expect. If hormone therapy is not right for you, Maybe you have a health history that makes hormone therapy off the table, or you've simply decided it's not for you. You still have plenty of options. Double check, because they did take the black box warning off of the estrogen for a lot of people that are concerned about estrogen and cancer. There was studies done that allowed them to take that black box off so it can be safe. So it is known to be safe. Double check with your doctors. Vaginal moisturizers used regularly, using those separate from lubrication during sex, that helps rebuild your tissue over time, where lube just kind of gets things wet. So it's important to make sure you're building that tissue. You have pelvic floor therapy. Yes, that again, because it comes up constantly for a reason, improves your blood flow and tissue elasticity. And longer, unhurried arousal time before penetration matters more than it used to, because tissue that's had less estrogen needs more time to respond. None of this is a downgrade, once again, from hormone therapy. It's just a different toolkit. Low testosterone. We mostly talk about this in men, but it's in women too. Women have testosterone as well. And a drop can affect desire in women just as much as the estrogen affects women. It just gets talked about far less. In men, how testosterone often shows up is low desire, fatigue, mood changes, and sometimes erectile changes. So here's what most guys skip entirely: getting it actually tested, and tested correctly. Testosterone should be drawn first thing in the morning, because levels naturally drop throughout the day. So if your desire completely dropped off that cliff and you've been blaming stress or your relationship, ask for blood work before you assume it's psychological. And if levels come back low, make sure you're double checking they do your free testosterone as well. Have an honest conversation about testosterone replacement therapy. There are genuine benefits and genuine considerations, and that's a decision to make with a doctor, not a forum post. Testosterone in women going through menopause. We touched on this already, but it deserves one more moment, because when I tell some women to go get their testosterone checked, their GYNs say we don't need to check it in women. 100% we do. Many women are never offered testosterone as part of their menopause care, even though it plays a meaningful role in desire, energy, or even mental clarity. So if your doctor's menopause conversation only covers estrogen or progesterone, that's an incomplete conversation. Ask specifically about testosterone levels and whether low dose T therapy can be appropriate for you. Let's talk about your thyroid, the one that nobody thinks about. It's an underactive thyroid can tank your energy and your libido at the same time, and it gets misdiagnosed as depression more often than you'd think, because the symptoms overlap so much. Fatigue, low mood, weight changes, low interest in things you used to enjoy, including sex. So an overactive thyroid can do the opposite, sending anxiety and heart rate up in ways that make relaxing into intimacy nearly impossible. So either direction, there's a simple blood work panel that gets missed constantly because people, and sometimes their doctors, jump straight to blaming stress, your age, or the relationship itself. Thyroid symptoms get misdiagnosed as depression constantly because a basic TSH thyroid panel often gets skipped in favor of just jumping straight to mental health explanation. So when low mood and low desire show up together, that panel should be part of the workup before anything else. So I want to bust a few hormone therapy myths. Let's clear up a few things I hear constantly. Myth 1, hormone therapy is dangerous for everyone. The research has evolved a lot since that study that scared a generation of women away from it in the early 2000s. And so this is what I was talking about with the estrogen before. For many people, particularly when started within 10 years of menopause, the benefits outweigh the risks. But that's an additional conversation with a knowledgeable doctor. Myth number 2, testosterone replacement will automatically fix your sex life. It can help if you're actually deficient, but it's not a magic switch. Using it without blood work confirming you need it can cause its own problems. Myth number 3, once your hormones shift, That's just how things are now permanently. No, bodies keep changing. What doesn't work today might work in 6 months with the right adjustments. And what does work today might need revisiting tomorrow or a year from now. So treat this as an ongoing conversation with your doctor, not a one-time, this is it. And so I want to talk about talking to your partner about hormone changes. This deserves its own section because so many people suffer through hormone-related changes in complete silence, worried that their partner is going to take it personally. So here's a simple script. My hormones are fucked up now. You can just say my hormones are shifting right now, and it's affecting my desire and my body's response. It's nothing about you. I want us to figure out what still works together. So that sentence does an enormous amount of work. It removes blame. It's talking about your hormones. It names the chemistry, saying that they're shifting, and it invites your partner into problem solving instead of leaving them to guess where maybe they did something wrong. So here's something that also doesn't get talked about enough. Hormone shifts rarely hit both partners or a couple at the same time. One person might be deep in hormone-driven low desire season while their partner's desire is completely unaffected. And nobody's talking about the chemistry underneath. That gap gets misread as rejection instead of what it actually is. Biology. It's just biology in two different timelines. So this is exactly why understanding the mechanism matters. And so once you know a medication is affecting your nerve response or your blood flow, you can address that directly instead of assuming something is wrong with your desire. So here is your hormone toolkit. Advocate for yourself. Ask directly about sexual side effects with any medication or hormone therapy. And don't let a rushed appointment brush past the question. Support arousal directly with longer warm-up time, toys, lubrication, especially when desire is slow to catch up. Time your intimacy around when your energy and your symptoms are most manageable, and shift your mindset. Separate desire from your performance and stop comparing your current chemistry to your body 10 or 20 years ago. So a quick note before we wrap up this segment. Some of what affects desire hormonally overlaps with mental health medications, particularly SSRIs, which is its own enormous topic. So we're going to go deep on that in another episode in 2 weeks, but it totally deserves its own full conversation rather than just rushing through it here. So if that is part of your situation, stay tuned for 2 more weeks. Your hormones are not betraying you. They're sending you information. So treat hormone shift like data, not just a verdict on how your sex life is going to be the rest of your life. So get blood work, talk to your doctor, and in the meantime, learn the tools that actually help. Lube, patience, longer warm-ups, and telling your partner what's actually happening in your body instead of pulling away and letting them guess. And get coaching if you need some extra support. So if you have not had blood work in the last year that specifically checks your hormone levels relevant to desire, estrogen, testosterone, thyroid, free testosterone, progesterone, book that appointment. Not because something is necessarily wrong, but because you deserve that actual data instead of guessing. And that can give you a baseline. So when things feel a little more different, you actually know where you're at. So don't forget, if today's episode made sense to any of you and you said, aha, that's me, my pleasure playbook, Desire with a Diagnosis, goes even deeper. It's a step-by-step guide, practical tools for pain, medications, surgery recovery, and rebuilding intimacy on its own terms. There are over 16 different pleasure playbooks that I have on my website, drstacyfriedman.com, under the shop link for Pleasure Playbook. But this one is called Desire with a Diagnosis. There's things on women's issues, men's issues, menopause, porn, connecting, kink, fantasy. Something in there has your name on it. I guarantee it. They're only $27 each. You can start the moment you get the download. The link will be in the show notes. So grab yours and start making the changes that you've been putting off. You've already taken the first step by listening. Now take the next one. So my permission slip for today is that you are allowed to want sex even if your body needs accommodations. You're allowed to grieve how easy sex used to be and still get excited about what it can become. You are allowed to laugh. Let's all laugh, please. Mid-position, when your knee has something to say, or you can't stand up or lay down or go on the side like you used to. You're allowed to laugh. You're allowed to get a pillow, take it slower, or still feel like the hottest version of yourself, because you are. Your body earned every scar, every surgery, every hormone shift, and it still deserves pleasure. So that is a wrap on another episode of the Purple Passion Project, where we show up, go deep, and never once pretend that your sex life does not matter. Until next time, stay curious, stay turned on, never apologize for wanting more, and remember, your sex life doesn't have an expiration date. Now go live it.
This has been the Purple Passion Project with host Dr. Stacy Friedman. Tune in each week as Dr. Stacy breaks down walls, busting myths, and gives you permission to want more with no shame, no filters, and definitely no small talk. Check in every Monday, 7 p.m. Eastern, on your favorite streaming platforms. We look forward to seeing you next time. Be sure to visit drstacyfriedman.com to learn more.